name is Jason. I'm a CT Tech at University Hospital, and my topic is going to be on advancements in cardiothoracic imaging with wide volume perspective gating protocols. I've got nothing to disclose. So some of our learning objectives here, we're going to talk about the CT technologist's role in these new protocols and how we, on our end, can optimize images for radiologists. We're also going to talk about the impacts on quality improvement and patient safety from these new protocols. And we're going to talk about some future research opportunities. So to start off, we'll compare the old versus the new way of scanning. The old way used a GE scanner that did an axial perspective gating protocol, or APG for short. This was a 64 slice detector with 0.625 millimeter slice thickness. That gave us a z-axis coverage of about 4 centimeters. So when we were scanning the heart, it would require the scanner to scan, move, until the entire heart was scanned. This typically took several heartbeats. And when we compare that to the new scanner, which is a Canon that uses the wide volume perspective gating protocol, or wide volume for short, we have 320 slice detector with 0.5 millimeter slices, and this gives us a substantially bigger z-axis coverage of almost 16 centimeters. And what that does is that allows us to have the scanner only move once to scan the entire heart and thoracic aorta. And that means it can be done in just 2 beats of the heart. And we also, with the new scanner, we have some new software and reconstruction algorithm updates, such as the cardiac ACE-MALD reconstruction algorithm. So now we're going to get into the tech side of things with the wide volume setup. Whatever is new is going to be bolded. So just as the old scanning protocol, we still apply 4-lead ECG for cardiac gating. We use some scout imaging. And then after the scout imaging, the first big change that we do is we do a small NC scan to find exactly where the heart ends and when we exit the heart. And this is very important when we set up our actual scan, as it will help us combat something called slab artifact, which we'll get into in just a second. Next, we do a timing bolus, same as our old scanner. This just tells us when we'll get peak opacification of the structures in the heart and the aorta. And then we get into adjusting our scan parameters. So if you look at this picture here, the top blue line, so the top blue line to the bottom blue line is everything that's going to be imaged. And the 2 yellow boxes here are the 2 volume scans. This middle blue line here represents the area in which the 2 volume scans overlap, and that's where we get that slab artifact. So it's very important for us as techs to ensure that we get this bottom blue line here as high up as possible, so that we get as much of the heart inside as a bottom volume scan, so that slab artifact doesn't really limit the radiologist's ability to make a diagnostic assessment of the heart. If sometimes the slab artifact is significant enough that we as techs have to go into the background data, and luckily we can still fix this because the scanner will scan just a tiny bit below and a tiny bit above this blue line, so we'll just send the 2 volume scans individually. And on our part, that's really great because that means no matter what, we'll get a good scan for the radiologists. Next, we do a breath hold exercise, and then we scan. So now, if we get into comparing images, on the left we have our APG, or our old way of scanning, and on the right we're going to have our wide volume scans. And just off the bat, which looks like the better scan from an image quality perspective, the wide volume scan is significantly better. There's a lot less graininess going on. There's a ton of graininess in this image, a lot of noise. And this wide volume scan is very clear. It's got great image quality. So what you would traditionally expect is that with this new scan here, when you're comparing these 2 scans, you'd expect that with improvements in image quality, it usually comes at the cost of dose to the patient or radiation dose. However, when we looked at comparing the dose, and we compare the dose using dose length product, which isn't the amount of absorbed dose, but it's a measure of the radiation output of the two. The APG scans had a total dose length product of 579 milligray centimeters. And now when we look at the new scan, our wide volume scans, we had a dose length product of 273 milligray centimeters. So that's a very substantial difference. That's almost 53% less radiation output. But the key is that it also had improved image quality, which goes totally against the norms of what you would expect. So now, knowing this and looking at various other studies with similar, or various other scans with similar results, future research should focus on comparing dose reports from APG to wide volume scans across multiple studies, patients, sorry. Two main metrics you can do this are the CTDI, which is the dose in a single slice, and the dose length product, which is just the radiation output across the entire scan. The second outcome we could look at is comparing image quality. You can do this subjectively with a blind review of the two scans by the radiologist and simply having them rated on a scale of 1 to 5 for how much noise there is, 1 being a lot of noise, very poor image quality, 5 being perfect image, no noise detected. You could also look at it objectively with a region of interest tool that can measure the signal to noise ratio in the image. And that looks a little something like this. And you can actually do this in packs. Basically what you would do is you draw a ROI over a piece of anatomy, so you can hear it's drawn over the ascending aorta. And that would give you a signal noise ratio number. And that number is proportional to the image quality. So the higher the number, better the image quality. That's everything for my presentation. Thanks so much for listening, and special thanks to Dr. Gwala for taking the time to make this protocol with their cardiac grads.
Was there any questions?
I have a question. What accounts for the less dose? Is it just the scanner improvements that the dose is less?
The scanner improvements, yes. The new software as well allows us to use less dose. There's also a possibility that because you are repeatedly scanning over and over again, there's a lot of that overlap and the dose sort of spreads up and down from there. So since we're doing it in just a single rotation, there's less of that overlap between every scan, move, scan, move, scan, move. So that could be a potential reason, software upgrades. Yeah.
I can kind of answer that a little more detail. Great talk, Jason. Part of the, there's a lot of detail in this protocol. There's the acquisition side and then there's the reconstruction side. So it's a great observation. It's actually more on the acquisition side. And Jason did mention on one of his slides that one of the reconstruction algorithms, it's in there something called PACE. And it happens to be Kern's brand name for a deep learning reconstruction algorithm. And this is thematically called a whole lot of the vendors are doing. So what that lets us do is actually undersample the data compared to what we would have done conventionally in CT for a long time. This is happening not just in CT, it's happening in a lot of other modalities. So yes, it's actually on the acquisition side. Jason's right, there's part of this will be a the style of scan that we're doing, but a lot of it is just that the photon flux is way lower than what we would have done before because we can deal with that on the software side. So everybody's familiar with their smartphones and the computational photography that's going on, and your iPhone takes these amazing shots with these tiny little apertures. Same idea is it's happening on the medical imaging side. For CT, that's what's happening. So it's a deep learning reconstruction. It's letting us take undersample data and really bring out a lot of the information that's happening.
And also, because we've got a bigger generator, we can use low kV and higher MA. Right? So as the chief said, what you said, with helical scans, there's 20% overlap with the beam, right? Because you have to reconstruct. You don't get that with the wide volume. We're using lower KVs with a higher MA, so we can get lower dose. The reconstruction pace is important. The other thing to mention is when we do native cardiac, you show the cardiac heart rate order, but when we do just cardiac, that's one slack, 0.27 seconds. And so those of you who do X-ray, who does X-ray, chest X-ray? Imagine doing a chest X-ray on a patient, hold your breath, and you can only image this bit at a time, so you have to connect it up. What's the likelihood the patient's going to breathe? Okay? So what Jason's saying is, we've got rid of that by being able to do the whole right and left slab, right? And even if the patient breathes, as long as they breathe within that slab, you're going to get a great image. So the advances in CT technology have been able to help address the gap that we've got right at. Now, if the tube could spin faster, we wouldn't have to get the heart rate down as low as we have to do right now. So there's still advances they need to do. But that gantry weighs about a ton, and it's spinning at 0.27 seconds. So there's G forces involved. Jason said he'd have a handle and crank it around. He's doing the gym
Working on it.
We're not sure we can spread that across the country. Great presentation. Well done.
Yeah, awesome.
Great presentation.